Good morning, everyone. I'm Linehan Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, I'd like to welcome you to today's webinar entitled Dialectical Behavior Therapy for Individuals with Substance Use Disorders in Brief. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and to me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor, and the presenter will answer questions at the end of the presentation today. Our audio is being broadcast through the internet to your computer. However, so you can listen to the presentation through your computer, but if you do have difficulty with that, you can also utilize the telephone feature. And you can do that by joining the webinar and call in using the telephone I will call in option. And you'll see that on your panel as you join us. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. To access that recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FADA website. If you would like to receive CE credits, that's continuing education credits, or a certificate of attendance for this event, you must complete the evaluation. Please be sure to include any Florida license number as applicable for reporting to CE broker, along with a prefix for your license number. And again, the certificates of attendance will be delivered to your email address within 5 business days. Do note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to give partial credit for these events. After this training, participants will be able to name 3 observed differences in those with borderline personality disorder and substance abuse disorder compared to those without substance use disorder. Participants will be able to define dialectical abstinence and will be able to generate 2 examples of attachment strategies. I'd like to introduce our presenter now for today's webinar. Linda Dimeff, PhD, is Institute Director for the Portland DBT Institute. Dr. Dimeff facilitates the training and dissemination of dialectical behavior therapy and other evidence-based therapies. Dr. Dimeff also serves as the Chief Scientific Officer at Evidence-Based Practice Institute, where she develops and evaluates emerging technologies that have the potential to transform training and delivery of EBTs. Trained, supervised, and mentored by Dr. Linehan, Linda is a DBT expert clinician, consultant, and supervisor with specialty expertise in DBT for substance abusers. Linda is the 2011 recipient of the Is It DBT Cindy J. Sanderson Outstanding Educator Award. Linda also served as a standing member of the Mental Health Services Research Grant Review Committee for the National Institute of Mental Health and is adjunct clinical faculty at the University of Washington. Linda has received over 20 federal grants to facilitate the dissemination of evidence-based therapies and has published over 50 peer-reviewed publications. She is the first author of Brief Alcohol Screening and Intervention for College Students, a Harm Reduction Approach, and the primary editor of Dialectical Behavior Therapy in Clinical Practice, Applications Across Disorders and Settings. She is a Linehan Board of Certification certified clinician. And we're very pleased to have Dr. Dimeff join us today. And Dr. Dimeff, I'm going to go ahead and get your presentation loaded up here just a moment.
Thank you, Leanne.
And I'm going to turn control of the presentation over to you now. And
Fabulous.
Remember, Dr. Dimeff, you'll want to click once inside the navigation window, the panel there, and then you should be able to, there you go.
Fantastic. Thank you so much, Leanne, and also Cynthia for both inviting me and doing all the prep behind the scenes work to make this possible, and Leanne for your lovely introduction. And I just have to say to all of you, it's a complete honor to be here, and I so appreciate the opportunity to speak with all of you. And I had to chuckle a little bit in that intro only because, you know, that's what happens when you're really old, right? Like you just start mounting a lot of work. So if you heard me laugh, I forgot that I wasn't on mute during that period of time. That was why I was having a little chuckle. Anyway, so here we go. And I just want to say at the very beginning, you have a lot of slides in your slide pack if you do have already the PowerPoints, and we're going to be going through some very quickly, and we're going to be going through some in more exquisite detail. And so you can just see the materials when you get them, or if you have them already, as a reference guide. And the other thing I just want to mention is, you know, just in terms of our learning objectives, I guess I just want to say, let me see if I can go back here. And I guess I'm probably just going to state the obvious here. So, you know, DBT is a pretty complicated treatment to learn and do. Some of you already are exquisitely aware of just how hard it is, and others, you know, you may have more peripheral understanding of DBT. The reason why it's so darn complicated is because the patients themselves are complicated. They have many, many problems that we need to know how to treat just from a mental health, behavioral health perspective. And they also are just complicated to treat, and all kinds of things occur in session that makes it sometimes even more challenging. So I say this only because my hope as we think about, you know, today's talk, like my goal is to make sure that everyone, whether or not you have an interest in learning or doing DBT ever, takes away something that will be helpful. And for those of you who have an interest in DBT, or perhaps you're already super well trained in DBT, and this is really kind of an added on layer, that the effect of this webinar is one that creates both excitement and curiosity to learn more. So I hope that's a reasonable expectation, and you will let us know. So, you know, in the beginning, way back when, sort of in the late 70s, early 80s, Marsha endeavored to create this new treatment, and that we now know is dialectical behavior therapy. And the thing was, to be perfectly honest, she was not interested and really didn't understand and know about borderline personality disorder. Her interest was chronically suicidal patients. She wasn't trying to do anything unique and special. She really was a rock-solid cognitive behavioral therapist, and she was simply looking to address the problems of chronically suicidal patients using CBT, cognitive behavioral therapy. And the more she got into it, all of these adaptations that ultimately became, a new and now called third-wave treatment were required in order to treat this population. And, the fabulous news at this point from, her pretty humble beginnings there, where there was just a handful of studies, but and the enthusiasm was way greater than the handful of studies. At this point, there's actually over 30 randomized controlled trials and literally dozens and dozens of non-controlled trials supporting the effectiveness of DBT for a wide range of patients. So now you have a number of slides here, and these are straight out of the DSM-5 that describe the criteria. And I suspect that all of you already know this or have easy access. So rather than going sort of slide by slide, what I really want to be able to do, so you have these, again, these are going to be part of your reference materials. But what I really want to focus on is how in DBT we think about borderline personality disorder. And certainly we take all of those diagnostic criteria from the DSM-5, and Linehan organizes them in a particular way as 5 domains of dysregulation. And so you can see here and then also in the next slide those 5 domains. And they really map on to the criteria. So you've got both emotion, dysregulation, interpersonal, where you see all kinds of chaos in relationships and difficulty. And you see this often in therapy as well. Self-dysregulation, which is really the experience of a sense of profound emptiness, as well as just really not knowing who I am and what I stand for. And sort of like I'm a chameleon, my identity gets shaped based on who I am in the presence of. And this is super important, by the way, as you think about something that I just want to kind of make a, how do you say it, pin this now for the future. But when we think about functionality and what's important in terms of, you are and you become influenced by the context that you're in. So if you have borderline personality disorder, this is oftentimes for many people super important, because either it will pull you in the direction of being more of a mental patient and dysfunctional behavior, or it can pull you in the direction of functionality. That's not only true of BPD, but it's certainly true of BPD. So, and then again, thinking more about these areas and domains of dysregulation, we also have behavioral dysregulation, which is where you see all of the impulsive behaviors, including suicide, including non-suicidal self-injurious behavior, and certainly also what you all are super familiar with, which is impulsive use and problematic use of alcohol, drugs, and over-the-counter medications and prescribed medications. And then finally, the final area here is cognitive dysregulation, and you see that a lot in terms of both paranoid ideation, dissociative responses. Again, these are mapping onto the criteria, and under the state of intense emotional arousal, kind of a narrowing of attention that creates more conditions of cognitive instability, where you're really not seeing things actually as they are. And I don't mean from a psychotic perspective, I simply mean more from you may see the event but your perception of what's happening becomes problematic. Now, I want to go back to this because the granddaddy of them all from our perspective in DBT is that borderline personality disorder really is a problem of pervasive emotion dysregulation. And you may have heard that expression over time. From our perspective, borderline personality disorder really starts off with a brain disorder transacting with an environment in a particular way. And the environment may not necessarily always be an abusive one. Oftentimes it is. Sometimes it's simply a mismatch between the temperament of the person who has borderline personality disorder and a brain that is super emotionally sensitive to emotion, interacting with an environment that isn't really set up to understand the exquisite sensitivity of a person with BPD and their hyper-emotional brain, and then inadvertently and sometimes intentionally can result in invalidating the person. There's a lot more that we can say about that, but that gives you kind of a little bit of a framework for how we think about borderline personality disorder. Now, we're going to be really segueing into BPD and substance use disorders. So just first, if you look at the general population, you can expect that somewhere around 2.7, although in some studies it's as great as 5% of the population meet criteria for borderline personality disorder. So we're not really talking about a small segment if you think about the size of the U.S. and certainly the international community as well. Now, in terms of the overlap of borderline personality disorder and substance dependence, what you see in chemical dependency treatment settings, so those settings that are specifically treating drug abuse, you can expect that somewhere between 9 and 65%, I realize this is a huge range, of the patient population will meet criteria for borderline personality disorder. So again, moving from that general population stat to community samples of those seeking treatment for drug abuse. Now, you can look at it from another perspective as well, which is in community mental health, what percent of the population can you expect to have borderline personality disorder and substance dependence? So they're there because they have BPD, or perhaps that's not why they came. They came because they're super anxious, or they have terrible flashbacks, or they're cutting, but through diagnosis, you realize actually they do. So in that population of people seeking mental health services, you can expect that somewhere between 21 and 67% of the population will also meet criteria for a substance use disorder. Now, this years ago, actually 7 years ago at this point, I went to a conference that was specifically on BPD, and Michael Stone, who is a psychiatrist that has devoted his entire life to studying a sample of about 550 people with borderline personality disorder, he was presenting data from his 40-year follow-up. So imagine this man has been tracking 550 people over the course of his career up to the time of this data where he was in his 40th year of looking at what had happened to this population of people. And he was specifically interested in knowing of the population, how many ended up dying by suicide, taking their own lives. And so what he found was that the suicide rate of that population was about 9%, primarily folks killing themselves, those who had BPD in their 20s and 30s. But notice the next bullet point here. That number, 9% suicide rate, increases to 38% if the person was an alcoholic, and I'm using his words here, and they were not in Alcoholics Anonymous. So now that could be, you know, that they didn't have a program of recovery. I would think, you know, maybe being in AA was super important, but it may also be that it was simply not having the alcoholism appropriately addressed in a way that was enduring. Now, in terms of the best outcomes, what he found is those folks who ended up having the best overall outcomes, not only clinically, but in the rest of their life, were, and this isn't super surprising, they were artistic, they were super smart, so they had IQs over 130. They were conventionally attractive, and he described having a good sense of self-discipline, which from a behavioral perspective, we might think of that as self-management. But the other point is also super important, which is that they were abstinent from alcohol and drugs. So in this point, particularly around alcoholism, you know, we find again and again in the research literature with borderline personality disorder and suicide, that if you have a suicidal client and you have and they are alcoholic, they are much more at risk for suicide. And I'll come back to that in a moment. Okay. Now, if you look at those with the poorest outcomes, you can see some of these were predictors of poor outcomes from Dr. Stone's work. So when we think about the challenges, those of you who have either intentionally or unintentionally worked with people with borderline personality disorder and substance abuse, you will know this, but they are, in comparison to other populations, they have much higher rates of psychosocial impairment. They're more suicidal, including non-suicidal self-injurious behavior. Their substance abuse oftentimes is more intractable. They are non-compliant, and they have higher rates of relapse. They have much more psychopathology, and there's been a number of studies that show that, in fact, they have poor treatment outcomes. Now, this is a study that was conducted a while ago, and you'll see the impact, and this had a major impact on our own thinking about why it was necessary to not only think about to figure out why the importance of creating an adaptation for this population. And so here's what Paul Links discovered. He was interested in knowing, again, on this degree of psychological impairment and difficulty to treat. He was interested in really examining the differences between folks who had BPD only, BPD or substance abuse only, and BPD and substance abuse. So what he found is that if you have this combination of BPD plus substance abuse, you have, again, a much more challenging patient. And the problems, the degree of and severity, the number and severity of the problems are exponentially more when you have that combination of BPD plus substance dependence, much greater than if you have BPD only or substance use disorders only. And they're, again, also a greater risk for suicide. So this sort of provided a bit of the foundation for why the National Institute on Drug Abuse suggested to Linehan way back when that she consider an adaptation and really studying this patient population because of the known complexities of treating this. And for those of you who are actually DBT practitioners, if you look at where Linehan's interest in consultation team became even more keen, and had always been keen, but really where she began to talk about and lecture more on the importance of consultation team, it was right in alignment with when we began doing our research because of the complexity of these patients in comparison to these other populations. All right, so now if we think about the implications for treatment, you know, this is true of standard DBT, and it's certainly true in our treatment with drug abusers. So DBT for substance abusers, we are an abstinence-based treatment, sort of, and I'll come back to my sort of in a moment. It would be our preference, to be perfectly honest, if our clients were abstinent across the board. the challenge only is that you can only work on so many problems, and they have so many problems. So just to flag that for now, but overall, we're an abstinence-based program. Now, if anyone wants to know why during our Q&A section, I'll certainly I can address in more detail why, but my guess is for many of you that makes a lot of sense. But we're not only about abstinence, and this is where DBT always had equal emphasis on functionality. And honestly, pragmatically, borne out by the research literature, the way to actually help someone reduce their mental health problems or their drug addiction problems is actually by simultaneously creating and building and sustaining functionality. So one of the things that we do right away when we're working with a person with substance abuse who's not working is that we work with them on getting a job, even if it's volunteer work, even if it's day labor, but where they are beginning to re-enter, if you will, mainstream in some fashion, that we're helping them, pulling them in the direction of mainstream activities like work, where the goal is functionality. So these things, they really go hand in hand. They're two separate goals, but they transact. The more functionality you have, obviously, it's easier to be abstinent. The more abstinence you have, it's a lot easier to have greater functionality. So let me just pause for a second and just hit this issue of abstinence in a little bit more detail so you understand, kind of what I mean when I say sort of. So, I'm thinking about, for example, one of my clients a number of years ago. This person was opiate dependent, alcohol dependent, thankfully in remission by the time that he got to me, cocaine dependent, and also dependent on pot. He was suicidal. He didn't engage in self-harm behaviors, but the suicidal behaviors were enough. He was serious. So when he was suicidal, he was not messing around. He would make lethal attempts. So, and he had a number of interpersonal problems. He wasn't working. So when he came, obviously one of my highest order priorities was to make sure that he remained alive, meaning he didn't kill himself, so that we would have an opportunity to work on everything else, and he could have an opportunity to enjoy the rest of his life. Okay, but the question is, so there I am with cocaine, pot, and heroin addiction. Now, the thing was, he was absolutely willing to continue abstaining from alcohol, so that was great. I wouldn't exactly say I didn't have to then worry about it. I still needed to worry about it to keep my eye on it. But where I needed to really focus the treatment was on these higher order, these drugs that he was still using, right? So he was absolutely not willing to give up pot. From his perspective, pot was not a problem. He absolutely saw how heroin and cocaine were destroying his life. So now the commitment that I got from him and our goals for treatment were for him to continue to abstain from alcohol and give up heroin and cocaine. And now the pot, I wasn't thrilled about it, but for the moment, I accepted it. Now, what I said to him, and this is a nuanced point for those of you who are practitioners in DBT, if in fact we discovered that his use of pot was connected to higher order targets, then we would have to revisit his commitment around pot, and we would have to put abstinence from pot back on the table. So in other words, if we discovered that when he was smoking pot, he was more at risk for using heroin, and we really couldn't get him off of heroin and cocaine because pot was sort of creating a kind of vulnerability that opened the door to these higher order targets that he agreed to. If that happened, then he agreed ahead of time that he would give up pot. So it's a little way for me to kind of get my foot in there, in the door, and say, look, if this is a problem, can we agree now, ahead of time, that you'll give it up? Now, in this particular case, actually, it didn't end up being a problem for him. He was able to give up heroin and cocaine while still smoking pot. Now, was I thrilled about his use of pot? No. And I'll tell you why. I mean, you may have your own reasons for that. So now, I'm from Seattle, Washington. At the moment, pot, marijuana is legal in the state of Washington. But at the time that I was treating him, it wasn't. So he had to, in order to get pot and use pot, he was engaging in illegal behavior, which, you know, was a problem from my perspective. But the other thing that was concerning to me is that his use of pot would actually interfere with a more important treatment goal, which was for him to learn behavioral skills that could influence the rest of his life. So even though DBT is a year-long treatment, and sometimes it's less, and you know, oftentimes we'll extend the treatment contract for more time, but at least in the research trial, it's a year, and that sounds like a lot, but not where you're having to overhaul a person's life. So I am very committed to the task of making sure that there are no barriers that are in our way for these clients to learn and practice in all relevant contexts DBT skills, so that they're learning new ways of doing it. So I wasn't super crazy about him using pot for really this reason that if he was using it a bit as an emotion regulation strategy. And then the other concern I had is that the way that he was using it just got him outside the mainstream enough that, you know, from an identity perspective, it would be very hard for him to not continue to have a notion of himself as a person who's a drug abuser. And that, of course, opens the door for relapse down the way. So, what I did do, in addition to my little foot in the door by saying if this is connected to higher order targets, what I did do is every opportunity I had, without being completely annoying, I pointed out to him I pointed out to him the problems associated with his use of ongoing use of pot, but in a way that linked to his goals. So concretely, one of the things that he cared a lot about was having a relationship with an intimate partner. And he wanted someone who was going to be loyal and really have his back, and that he could take home to his family and they would feel good about it. He wanted someone a little edgy too, and he wanted those kinds of other qualities that really marked stability. So the thing that I oftentimes said to him was, look, you know, I'm not making up the rules here, but if you want that kind of a woman is not going to be interested in a guy who's smoking pot every day, multiple times during the day. I'm just telling you. I didn't create the rules of the universe. I'm just telling you. So I would highlight the consequences of his action. In DBT and in behavior therapy, we call that contingency clarification. There were some other things that I learned about him later on that I also used to highlight that using pot wasn't such a great strategy for him in terms of him getting his goals. And ultimately what I saw over time is a reduction in his use of pot. Did he totally give it up? No. But did he move it from sort of like, just for lack of a better way of describing this, salt, if you think about, you know, various accoutrements that you have in your kitchen, salt versus vanilla. He moved it from a daily routine to something that was an occasional use. All right, so now, and while we're treating a person and we're working on functionality and abstinence, we're also attending to the higher order targets. And so specifically that's suicidal behavior, non-suicidal self-injurious behavior, and of course addressing all of those things that come up in therapy that interfere with the effectiveness of treatment, while simultaneously building resiliency and a life worth living. Now, there's a little error on your slide here. So this first little enhanced skills training, EST, that should actually be evidence-based treatments or empirically supported therapies is really what ESTs are. So why doing DBT? Because, and this is one of the questions that we were asked by NIDA, because DBT has always been a treatment that is effective for not just one singular or two singular problems, but for people who have lots of severe and complex problems. And the other reason why it made sense to all of us to contemplate doing DBT is because built within DBT in so many ways, there's this principle of effective compassion. So effective meaning that it has to work. It has to make sense. It has to be in the service of the person's values. It has to really help them build a life worth living, while simultaneously having a great amount of compassion and non-judgmental stance toward the patient population. And certainly, as you all know probably better than me, this is a population like people with borderline personality disorder who are oftentimes marginalized and judged, and there's a fair amount of stigma about having a substance use problem and a fair amount of misunderstanding about this being a brain disorder as opposed to a voluntary, willful decision that I have. Now, another reason why DBT made a whole lot of sense is because DBT, and it's certainly not the only treatment, but it is one of the treatments that really does this. It's a big house, and really, you can embed everything within that house. It provides you a structural framework, and within which you can address a number of different mental health problems and other behavioral health problems, and that you're being guided by principles and procedures, but not really protocols. So that allows for a particular kind of flexibility. And what I mean by that is that unlike some other manualized treatments where you're told what to do when, and kind of you have to do that in order to be in the model and maintaining fidelity or adherence to the model, DBT is different. What you do in any one session, and honestly at any one time, all totally depends on what is happening in that moment and in the past week and the patient's problems and what's working. So that's what I mean by it's a big house, so you can think of it too as just a big frame. And the other thing that is in DBT is that it really structures up the treatment environment and helps us figure out what lane we're in, and for that lane, for that mode of treatment, what are my specific targets? And what are your targets? What are the functions that I'm responsible for? What are the things that you're responsible for? So we can all sort of be on the same page as a team and community providing treatment to this difficult population. And, you know, just for what it's worth, this issue about structuring up the treatment environment, it turns out that if you look at the other evidence-based treatments for borderline personality disorder, this is key. You see this across the board as one of sort of the elements that's so important in treating borderline personality disorder. Again, whether you're doing dialectical behavior therapy or mentalization or another of the evidence-based practices for BPD. Now, when we got going with this, with our work initially, Linehan spotted, and these are really her observations that I'm sharing, a number of significant differences in comparison to those folks who had just suicidal, when do you get to say that? Just suicidal and borderline personality disorder versus those who had substance use disorder and BPD. So first, with the substance use disorder population who also had borderline personality disorder, we noticed in comparison to sort of our usual person with BPD who's just suicidal, that they were way, way more avoidant of cues associated with negative affect. Now, that unfortunately included things like coming to therapy, talking about their problems, sitting in a room, making eye contact. I mean, all of these things that that are kind of the usual stuff of therapy, right? And so in reaction to their to the difficulty being in the presence of negative emotions, they would just avoid. So that would mean they would avoid our messages, they would avoid coming to therapy, they would avoid calling us back, you know, you name it, they avoided it if it generated negative emotions. Now, the other thing that was different that we really had to think about here was they were quick to move to regulate their emotions. And again, in DBT, we're thinking about the primary problem is pervasive emotion dysregulation. It is a brain disorder. And by the way, as we have more and more capacity to look at the brain with fMRIs and MRIs and other cool brain technology, you see these differences in the brain that result in the conditions of pervasive emotion dysregulation. So when they became dysregulated, they would move, not surprisingly to any of us probably, to quick-acting drugs. Now, what you find with many people with borderline personality disorder is that they actually move to people. And this is important because for many people with borderline, when they have problems, they'll reach out and call their therapist. In fact, they'll call you so much that, you know, we've had to create within DBT ways of solving that and helping therapists treat what can be therapy interfering behavior while simultaneously making sure that phone consultation for suicidal patients is available. Now, with this population, we really had to figure out, because they were so accustomed to moving to quick-acting drugs to regulate their emotions, how do we wedge ourselves in to be able to actually coach them when they most need it? So that was a big problem that we actually had to solve. So they would even have the thought when in a moment of crisis they would want to, you know, they would want to use drugs, and they knew really it was a super big problem. You know, how could we get their brain to more likely think, oh, call Linda for skills coaching, she'll help me. So we had to figure that out. Now, this next point, they fell out of contact with us like all the time. And, you know, I oftentimes think about my colleagues in multi-systemic therapy. So multi-systemic therapy is a treatment for conduct disorder, one of the best evidence-based, family-based treatments for conduct disorder. And one of the best predictors of treatment outcome over there with that other population is, does the parent actually know where the kid is at all times? And for those of you who are parents, or if you're not a parent, you could think about a sibling or your partner, someone that you have close contact with. My guess is if I asked you, where's your kid right now, or where's your partner right now, you would be able to tell me in no uncertain terms. You might be able to tell me exactly the school. You might be able to tell me the class. You might be able to tell me the address where your partner works, et cetera. So it is a similar phenomenon that if I did not have in my little brain awareness of where my client was, the chances of them falling out of contact with me were super high. And what that would mean is, particularly early on in that first month and 2 months of getting off and staying off drugs, you know, they had to change, as you all well know, you know, everything about, you know, people, places, and things. And we would have a little game plan, a little roadmap for how they were going to be spending their time. I could see it. But the moment, you know, they lost contact and they didn't show up, you know, it literally could be weeks before they resurfaced. And really because of that phenomenon, and I mentioned this earlier, we as a team of therapists were way more prone to demoralization because we saw the stakes being so high, the need being so great, the adverse consequences, you know, losing their children, losing their housing, you know, losing their jobs in such a brief period of time when they fell out of contact with us and went back to using drugs. And even more than with suicidal patients, it was really, really hard. And so again, the team really had to come together and to support each other. And then finally, they oftentimes, in comparison to suicidal patients, just had few social supports that were positive influence in their lives to rely on. And, you know, what I have found now that's super helpful is to really, I mean, they'll say I've got no one, but, you know, to really actually spend a fair amount of time to go back and figure out who did they have before, so that you can be figuring out who might you help pull into the treatment, or who might you coach your patient to go back and to begin to establish that connection that they used to have but that they lost during their period of drug use. So these are, you know, some of the more major differences that we noticed that really influenced the modifications, some of which I'll be describing today. Now, I think just in the interest of time, in DBT, we have secondary targets. We have primary targets and secondary targets. Secondary targets are the patterns of behavior that interfere with your ability to work on a primary target being getting off drugs, for example. And so we're always in DBT looking to treat not only the primary, but also the secondary target. And these are the secondary targets described by Linehan for people with BPD, that if you learn more about DBT, you'll learn, and if not, and if you already have, you're familiar with. Now, what I want to just highlight in a really big way are the two main ones. And again, just thinking about the differences between people who were suicidal and BPD and our drug abuse, we found that these were, there's some slight nuances and also differences in terms of intensity. So on the emotion vulnerability side, emotion vulnerability is a secondary target. You can think of it as kind of phobia of emotions themselves, that I know, having a BPD brain, I don't have a BPD brain, I'm simply describing the person who does, that their experience is, they remember with exquisite sensitivity and awareness how vulnerable they are to intense negative emotions. And it feels a bit like they are constantly on this abyss that they will never get out of. And it just, you know, if the wind hits them just right, they will fall into that abyss and never get out. So there's this quality of like, I actually really, because my emotions are so out of control, they're so big, they're so out of control, and I don't have the ability to get them in control to down-regulate my emotions. They kind of walk around with this a bit. And as it relates to drug abuse, there is this experience of I can't tolerate it. I can't stand the pain. I can't tolerate the pain. Because if I do, and if I do give up drugs, I will fall into that abyss and there's no way out. So they're not going to tell you this, but this is you know, their experience. And then, so the other is self-invalidation. So self-invalidation you can think of as self-loathing, self-hate, where they are in a perpetual way, in a profound and perpetual way, invalidating themselves. Now, and you see this with, again, self-hate, self-loathing. I shouldn't be this way. I'm disgusting. Look at me. Now, for our people with substance dependence, the problem is that the one community where they actually feel they fit in, and it's sort of like another community of misfits or people who are fatally flawed in their mind, are drug abusers. And so what's hard is that, you know, there is this awareness that on the one hand, they've got to jump out of that reference group in order to actually save their life and have a life worth living. And yet they don't feel that they fit in when they look around, you know, with a non-drug abusing group. So, you know, one of the beautiful things about 12-step programs, of course, is that that's a community where you can both have a history of alcohol and drug dependence or abuse, and with a reference community that is clean and sober and supporting one another. Not always, but mostly, right? So whenever, clients are willing to do 12-step, boy, I just feel like that is so great for so many reasons, not to mention the fact that, they've got to quickly move into a new reference group and have something to do, people, places, and things that are not using. And where better than in 12-step, where there's meetings always around the clock, virtually online, or in your community, and places to go where they can get support in the recovery. Now, the final thing I just want to mention that has to do with the self-invalidation, the one kind of variant of self-invalidation is oversimplifying the ease of solving problems and unrealistic judgment. So the way that we saw this is sort of when a person has a slip or uses drugs and DBT, drugs that we've basically said are off the table, our goal is abstinence, then we would do a behavioral chain analysis, a really rigorous effort to understand behaviorally how did that happen. So the thing is, often they would say, oh, look, we don't have to talk about this because I've got it. Like, I totally learned my lesson. I'll never do it again. And so and interestingly, as we watched in, our clinicians, our fellow colleagues, they're so convincing that it's super easy to go, okay, right, you've got this. We don't have to focus on it. So I would simply want to say that is, from our perspective, an example of self-invalidation. It is oversimplifying the ease of solving a problem, and to just not fall into that problem spot of treating it as if it's not a problem when it really is. All right, so super quick, there's a lot that's been published in this area, in this literature, and I think what I want to do is just tell you I want to share with you the results of NIDA-5. And if you're interested, I could tell you more. Actually, if you go to the Linehan Board of Certification website, there's beautiful downloads that have all the research to date in the area of DBT, and you'll get very comprehensive, well-documented descriptions of all the research literature. I want to tell you our last study, which is this NIDA-5 at the University of Washington. So this was a study, it was multi-site, Duke University and the University of Washington, both men and women. This is super important because many of the earlier studies were with women only, and I just have to say having men involved made it so much more fun and energetic, and it was a hoot and way more complicated, which we can come back to a little bit later. Not so much complicated, but just a little bit. It really had to do just with sexual tensions and joking and banter that would sometimes happen in group that made it a little bit challenging. But that aside, so we were comparing DBT for substance abusers to individual and group drug counseling, which is an evidence-based treatment that you can find more about on the NIDA website. So it's one of NIDA's evidence-based treatments for people with drug problems, drug dependence. So we wanted a super rigorous control condition. This was the last big study that we did, and we're sort of progressing our way through making sure that in comparison to gold standard, how did DBT do? So just to say, both treatments were effective at treating drug dependence. You see DBT a little bit stronger for the other drugs that we were targeting, not just the primary drug of abuse. But where you really begin to see the difference significantly between the two conditions is on mental health outcomes, with DBT being significantly better across the board. So, and that kind of makes sense because we were targeting not only substance abuse, we were also targeting mental health problems. So, again, comparing DBT to a gold standard treatment for substance dependence, DBT was superior if you look at it across the board. All right, so I'm just going to spend a few moments and then we'll take a break, just kind of saying quickly the major other, there's many evidence-based treatments for drug abuse, of course, but just those that, in our view, are tightly connected to DBT that either influenced our own thinking or there's lots of overlaps. So just to begin with Alan Marlat's relapse prevention, Alan's perspective was always recovery is a process. It's not an endpoint. And as a process, people have slips. It's like no different than learning any other behavior for the first, or skill, or learning to do something different. Like usually for most of us, we're gonna, fall off the proverbial bike before we learn to ride a bike without the training wheels or someone holding us, right? And, we slip, we fall. And the important thing, I just want to go here super quick, is that every time you have a slip, there's an effort to behaviorally, thoroughly assess the problem behavior. So this is an example of what we call behavioral chain analysis, but for those of you familiar with cognitive behavioral therapy and, the ABC model, the antecedents, behavior, consequences, that is kind of the cornerstone of CBT, it's the same sort of thing. So a person slips, and rather than thinking that, it's a disaster and you've reignited the disease of addiction, we think more, okay, what can we learn from this? Now, I have these slides just to make the point that from Marlat's perspective, and this is exactly similar in DBT, rather than thinking of use as a relapse where you've gone backward, we like to think of it as a prolapse and having really a model that says, okay, how can this event, if we really make lemonade out of lemons here, actually propel the person forward, like faster even, maybe potentially, than they would have been propelled had it not been for the lapse. So it's very dialectical. It's this sort of paradoxical making lemonade out of lemons. So we're very consistent there. And Alan was my graduate school advisor, and I so adored him. But one of the things that he said to me at some point was like, listen, Linda, rather thinking of 3 strikes and you're out, you can think of 3 strikes and you're actually closer to your ultimate goal. So that's been super helpful and, certainly consistent with DBT and I might say the research literature. Few people, some people do have that experience of just natural abstinence. They stop and they maintain their abstinence, whether it's cigarette smoking or pot or alcohol or whatever it might be. Some people can do that, but for most of us, we're between 4 and 7 times of starting and stopping in earnest before we actually get the behavior of abstinence down. So the other thing before we take our break is, it's very similar in many respects to motivational interviewing. Motivational interviewing has often been used now as an add-on to cognitive behavioral therapy to really help prepare the ground for change. And in DBT, we have a set of commitment strategies that function very similarly to what Bill Miller developed in Sebrolnick in motivational interviewing. And including not only functionally it does the same thing, but there's actually overlapping strategies. Although what you see in DBT is a little bit more confrontation, meaning that the therapist is saying the hard thing and not only letting the data do the work. DBT shares a lot in common with 12-step programs as well. And if you think about the major dialectic in DBT, it is change and acceptance. And if you think about sort of the major dialectic in 12-step as summarized by the Serenity Prayer, it's change and acceptance. God grant me the serenity to accept the things I cannot change, the courage to change the things I can. Courage in DBT would be wise mind, and the wisdom to know the difference. So we're very, very compatible from that perspective. You change what you can, and that which you cannot change, you learn to radically accept. Now, here's just some other, there's, I'm sure, many more, and you may have others as well that are similar. But one of the things that I'd like to just mention is this notion in 12-step programs of repairing harm caused to others in the form of making amends. We also have that in DBT. and it's called correction over correction. So when you cause harm, when you make a mistake, you not only correct the harm, but you actually extend it even further. So it's not enough to just say, I'm sorry. You really want to extend that further and really do more. So I always think about, you know, when I was a Girl Scout and my mother was a Girl Scout leader, she would always say, look, we've got to leave the campground cleaner than when we arrived. So you're doing more. You're not just doing status quo with respect to your repair. So, Leanne, I wonder if this might be a good place for us to pause, and I will defer to you.
I think that's a great idea, Dr. Dimeff. Thank you so much. And I did want to, we've got 3 questions, and they're really sort of pertinent and relevant to what you've been talking about, sort of immediacy of what you've been talking about. I thought we would just tackle one because it's sort of a technical question right now, and then do the other 2 when we come back in 5 minutes. But the first one is just referencing a website. Back on slide 24, you referenced a website and something about there being a really good researcher there, and a couple of people asked about what that was and if you could read it.
I will indeed. Thank you for asking, everyone. So it's the Linehan Board of Certification website. And if you just went in and typed in Linehan DBT certification, you'll go there. What Linehan has done really, I guess it's probably a 10-year effort really, is that she's creating standards for clinicians and for programs so that consumers and, you know, hopefully at some point insurance companies will be better able to determine if a person is qualified to do DBT and if the program is certified. So that's the Linehan Board Certification website. It's just, there's a lot of great resources there, whether you choose to become certified or not. Thanks, Leanne.
Sure, thank you. And Linehan is L-I-N-E-H-A-N. Anyway, we can always make that available to you after the presentation as well. But thank you, Dr. Dimeff. We are going to take a 5-minute break. It's 11:02 according to my clock. We're going to start again sharp at 11:07. Thank you. Welcome back, everyone. This is Leanne. Dr. Dimeff, are you ready to take a couple of questions?
I am.
Okay, great. The first one is, for those persons on the line who are participating without a background in DBT, could you please explain higher ordered targets?
I can, and in fact, so here, these are the, so let me take a step back. All behavior therapies tend to have behavioral targets for what you're focusing on in treatment. And sometimes they're more explicit than other times. And one of the things that I mentioned about DBT is that DBT really puts a big emphasis on structuring up the treatment. So one of the things that structures up are the targets. So the targets for stage 1 client, I'm going to explain that to you in a moment. The targets for stage 1 client are decreasing after you get a commitment from them. So kind of in the pre-treatment stage, you want to make sure that they're on board and they're willing to do therapy. But once you've got that, you know, your highest order target is going to be decreasing life-threatening behavior, and that's imminent life-threatening behavior. So that's suicidal behavior, homicidal behavior, behaviors that put them at risk for dying imminently, like, you know, getting so drunk that you, you know, you drive your car and you put others and yourself at risk for being dead. And it also includes non-suicidal self-injurious behavior. So that is in DBT our number 1 highest order target for a stage 1 client. And by stage 1, I really mean for this population here that are severely out of control and where your goal is behavioral control. So these are the people who have borderline personality disorder and substance dependence. They don't have just ordinary problems in living. They have severe and pervasive behavioral dyscontrol. Our goal is behavioral control. So again, going back here to the stage or to the targets, that's number 1, followed by decreasing therapy interfering behaviors. That's anything you or they do that interferes with the potency of treatment, right? So that could be big things like not coming, but it also could be things like dissociating or attacking, you know, you or, you know, I had one clinician who, boy, after lunch, he was like a total mess. Like his attention would go, you know, super down. He just wasn't tracking his clients. So that, you know, is it understandable given a number of different things? Absolutely. Is it therapy interfering behavior? Yes. And then the third is decreasing quality of life interfering behavior. So this is going to be all of the various problems that the person has that are really significantly interfering with the quality of their life. So this is for sure, and probably at the top, going to be substance abuse or dependence, but it also may be homelessness, unemployment, panic disorder, being in an abusive, you know, relationship where there's intimate partner violence, poverty. So all of these other things may be other examples of quality of life interfering behavior. And then simultaneously, while we're working on decreasing these sort of top three, we're increasing behavioral skills. So I think that was probably a more elaborate explanation, but that would be it.
Thank you, that's perfect. And we do have two other questions right now, but Linda, I think we'll hold them to the end because you may yet cover them. So we're ready to proceed when you are.
Okay, fantastic. Thank you, Leanne. All right, so let me just see if we've missed anything here. So these are our DBT substance abuse treatment agreements. So DBT contains within it a lot of agreements that we make to ourselves as to each other on a team. We make commitments and we have agreements and commitments that we make. And we also have agreements that we make with clients, and we have agreements and commitments that we ask for clients to make to one another. So we try to stay away, for the most part, away from rules, but we're all about agreements. One of the agreements is that people are going to get off of all illegal drugs, that they actually don't sell drugs to other people in program. It happens. When it happens, what target do you suppose that is? You just contemplate here. Which target would selling drugs to other people in treatment be? Just to let you know, it would be therapy interfering behavior and just staying a little on the tacky side. Now, the other thing is that you have to appear to the astute observer, including people who abuse drugs, that you're not under the influence when you're at our clinic. Now, this is super important. So in contrast to many drug treatment programs that say, look, if you're using drugs and if you're dirty, you know, we don't want you to come, just, you know, stay away. Because for whatever the rationale is, our view is that looking clean when you're under the influence is a skill. And on the path to getting off drugs, it's actually important as part of building your life worth living and not losing your job or not, you know, having legal charges against you, that you, in some cases, are able to look to the astute observer like you're not on drugs if you are on drugs. So we can come back to that. It's a nuanced point. When people do appear under the influence, and believe me, it happens all the time, you know, we simply treat it. So we'll, you know, at a behavioral level, so person is, you know, looking sedated, we'll tell them to sit up in their chair and open their eyes. A person smells like alcohol, we'll ask them to, you know, to go use a mouth freshener, get some gum or something because they smell like alcohol. So, you know, and do you kick them out? We don't. And why? Because our belief, supported by the data, is that they've got to have these skills, and the only way they're going to get these skills is by coming to clinic, coming to group, and learning. Now, so in the case of opiate-dependent people, we do encourage the use of opiate replacement medication. So hence this last point that they will agree if they're on opiates, if they're addicted to opiates, that they would take an opiate replacement medication. And also one of the agreements we have, largely because we were research, but honestly it ends up being super important clinically, is that they're willing to actually do drug screening throughout the week. And we, for purposes of research, did, you know, the highest, the most gold standard, which was urinalyses. But that's, you know, beyond certainly what we're able to do at Portland DBT in our clinic. All right. So we've talked about, so just kind of going back again, so you've got the lay of the land, stages of treatment, you know, usually for most problems that people show up to therapy for, like, you know, I'm depressed, I have panic, I'm not sleeping well, and having marital problems, you know, those are kind of stage 3 problems. The person is, you know, pretty much able to cope with their life, but they have ordinary problems, and the goal is ordinary happiness and unhappiness. again, I've highlighted for stage 1, we're really talking about severely out of control patients. Now, I do want to highlight an important stage 1, stage 2 thing. Now, many people, when treating clients with trauma, severe trauma, will have an approach and a belief that the way to deal with trauma is by, really directly targeting the trauma. So Linehan, her position has been the following, and the perspective is that you've got to be able to have behavioral skills on board to actually handle and manage dealing with trauma so that you don't end up killing yourself in the process. So I hope that makes sense. So what stage 2 is, oftentimes the person is no longer, they're engaging in out of control behaviors, but there's this kind of quiet level of desperation. And the goal, the treatment goal, is emotional experiencing, and or trauma work. But again, our position is that, and there's exceptions to this, but they truly are exceptions, that you've got to get a person to have behavioral skills so that they no longer are engaging in impulsive, out-of-control behaviors, so they can actually effectively tolerate your stage 2 work. So I just mentioned that because it's whether you're doing DBT or not, it's something important to contemplate. What stage is my client? And potentially getting them stabilized with behavioral skills before introducing exposure-based trauma work. All right, so now we also then had to develop behaviorally specific targets for treating drugs. So path to clear mind are the targets that we generated for DBT for substance abusers. And just to put this in context, path to clear mind, so I'm trying to go back here on my slide. So quality of life interfering behaviors, that's where you would include substance dependence, and then the specific targets for substance dependence are these. So, these are not exactly in hierarchical order the way the others were. You're going to have variations based on your person. So you might have some clients who really don't have any physical distress. And really, their bigger issue is not physical stress and urges, but it's all the ways in which they leave options to use drugs open. They've maintained contacts. They haven't gotten rid of their means. They are still hanging out with their drug dealer. It may be for your person that actually decreasing options, contacts, cues to use is higher in this rank order. But so nonetheless, you can kind of see, and we're not going to go through each of these in great detail or really much beyond this point at all, but I do just want to say these are the targets. And my guess is you are naturally using these anyway in your work with alcohol and drug abuse clients. So moving to dialectical abstinence, when Linehan first began sort of thinking about, well, how were we really going to do this, and help people get off and stay off drugs, and how, what is the model that we use here? In the research literature, as you all are well aware of, there's a body of research that really is sort of taking an abstinence-only approach. And then there's this other body of literature that's more taking a harm reduction / relapse prevention approach. And there's real pros and cons when you look at the research literature for both of these different models. So if you look at the abstinence model, what you see is that you get from the time that a person stops using to the time that they slip or have a relapse, you have a longer interval of time. But the downside is that, when you fall, you fall hard. So you may be familiar with this concept that Alan Marlatt initially articulated of the abstinence violation effect, or the goal violation effect. And he observed this phenomenon that when people did fall or slip, that they made a particular kind of attributions that were causal, that this is something that's inside of me. It's always been this way. It's a stable quality of me, and it kind of cuts across everything that I do. So if you think about those secondary targets that we talked about earlier on, and remember I emphasized specifically emotion vulnerability in self-invalidation, this is a little bit like it's Marlatt's version of the self-invalidation, right? That, you know, I've always been a screw-up. This is just another indication that I am a screw-up, and I always will be a screw-up because it's a stable characteristic of who I am. So again, you know, the pro of an abstinence model is that you get this interval of time, but when you fall hard. If you think about, you know, typically there's super intense negative emotions. We've already talked about how our population, meaning those with BPD, are people who are already emotionally sensitive, exquisitely emotionally sensitive, and their problem is pervasive emotion dysregulation. So this is no small thing, and for many people, when they fall, the primary emotion is what? And if you think about it, the primary emotion is probably shame for many of them. When you fall hard, the emotion of shame. And then Marlatt articulates that there's a number of factors that are likely to strengthen or increase the abstinence violation effect. So these are listed here as well, but not surprisingly, the degree of effort that you put to this goal and how much it really matters to you are all factors. So again, going back, the con of the abstinence model is the abstinence violation effect, and also that you're not actually helping people necessarily build coping skills to manage a slip. If you're kind of just, putting a, you can't see my hand gestures, but, driving a stake into the ground on abstinence only. Now, if we look at harm reduction, there's a lot of pros of harm reduction. So actually, one of the big pros is that you actually get, while that duration of period of time is less from the time that you stop and you start up again, when you fall, you don't quite fall as hard. So that's a real pro. And another pro is that you're actually, you're teaching a person how to use drugs. And then some people have this belief too, just in terms of cons, that, if you even entertain the idea that you might slip, that kind of opens the door. And from a dialectical perspective, there's validity in both of these positions, like absolutely. I mean, that is a true thing. Like if you're saying to someone, look, let's create just in case skills, you're kind of letting them know, like, you might use drugs again, and you think differently if that's your approach. So what we wanted to do then, and this is really Linehan's genius, she had this notion of dialectical abstinence, and what if it was a both and, as opposed to an either or? So either or is non-dialectical thinking, both and is dialectical thinking, where you're recognizing the validity in both points of view, and you're looking for what we call a synthesis that embodies the validity in both opposing points of view. So the notion is that we came up with this idea of total abstinence, but before any use and only in the moment, balanced with harm reduction. So the moment the person has used, you swing over to a harm reduction model, and you're there only as long as you need to be to get them back up. So let me just unpack that further a little bit. So while the person is clean, and only in the moment while they're clean, you as the clinician turn your mind fully and completely and with them that really they've got to stay clean. And it really doesn't take a lot of digging to describe why that matters. I mean, I think, you know, one of my first clients that I did DBT for substance abusers with, literally in a period of 72 hours, she lost her job, she lost her housing, she lost rights to her kid because she went and used cocaine. And so really, you know, you've got to help them see that truly any use is a total disaster. And so for this reason, they've got to just keep turning their mind to abstinence again and again, and denial really that any use of drugs is possible. And you kind of, and this is where, you know, you do kind of what works, you make an inner deal with yourself that, you know, I'm doing this, I'm going 100% making a commitment to not use drugs. But, and here's the really important thing, you guys, only for the period of time that I know with 100% certainty I can be successful. So this is the inner deal. And whether you're doing DBT or not, you might consider using this cognitive strategy. So again, so let me ask you this question, and or as if you were a client. What I would want to know is, what is the longest period of time you can go without using, you know, fill in the blank, let's just say pot. What, in the presence of the cue and not in the presence of the cue, how long can you go? Now, most people will say, you know, I can go a day, I can go a couple hours, you know, I can go probably a week because I'm not around the person. But when I get around the person, I can only be, you know, probably 5 minutes. So what you then do is that you make that commitment for that period of time, and then you remake the commitment the moment that that period of time is up. So just to make this even more concrete, you know, I used to bike to work. On my way home, there was a big hill. Now, if I looked at the top of the hill, believe me, it was a big hill. There was no way, there was absolutely no way I was going to be able to have the umph or motivation, whatever you want to call it, to go from the bottom of the hill to the top of the hill. Like, I would get so demoralized, my legs felt really heavy. If I looked at the top of the hill when I was at the bottom, I would just get off my bike. I couldn't do it. My self-efficacy, my sense of being able to do that was very low. But if I said to myself, actually, I'm going to bike only to the second car, and I'm making a 100% commitment with myself that I'm not getting off my bike, I'm making it to the second car, it was way easier for me to have the energy and motivation and ability to get to the second car. The moment I got to the second car, what did I do? I recommitted. I set my eyes on what was my next block of time going to be. So it was going to be 3 cars or 4 cars. And that's how you can get from the bottom to the top of the hill, even though it's hard, car by car, you know, day by day. And of course, in 12-step programs, just for today is the same idea. But notice it's a cognitive strategy. Just for today, there's not a person in 12 steps, probably, who doesn't on some fundamental level know that when they're making that decision, when they're saying just for today, they mean really for life. But the reason why they're saying just for today is because it's too overwhelming. So, and saying just for today is the equivalent of just that car, just those 2 cars. It's a strategy that allows you to get to the top. So that's what we mean here. When you're doing total abstinence, you make this inner deal with yourself, but only for the period of time you know you can do it with 100% certainty, and then you make that again. Now, and so these final 2 points, some people have found it helpful to say, look, I will not use drugs until, Linehan actually used to say that. She's a 3-pack-a-day smoker in remission. She'd say, listen, the moment I get a terminal diagnosis of cancer, I'm going to resume smoking. It was just a cognitive strategy. It wasn't like wishful thinking that she was going to go and get cancer. It was simply a way for her to make it during that period of time. or, you know, you in some future point that is really impossible. These are all just cognitive strategies, but that's on the total abstinence. The moment the person falls or slips, you now move from that notion of, you know, any use is a total disaster to actually a very different mindset. And now the mindset becomes the total disaster is not that this happened. The total disaster is if you don't learn absolutely everything there is to learn. And so, you know, we want to help you fail well. And failing well is learning from your mistakes. And we'll teach them about, you know, other examples of failing well. We'll tell them stories, for example, and this is true, that in the tech industry here in Seattle, where, you know, we have quite a bit of tech, as you probably know, it's not actually uncommon during interviews for an executive to be asked to describe the times that they failed. Now, why should that matter if you're hiring, you know, a high-power, expensive manager or executive for your tech team? It matters because the only way anyone does anything great is by screwing up and making mistakes. You've got to have a whole lot of mistakes before you actually get it right. You know, the iPhone, you know, while it's a beautiful thing of invention, is the effect of many, 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 many mistakes before they got there. So we'll teach them these stories, and we'll stay on this end just as long as needed to get them back up. All right, so that's really what we mean. You're kind of like walking between absolute abstinence and harm reduction only in the moment based on where the person is. So so here's just kind of a little summary if it's helpful, but you can think of dialectical abstinence as kind of explicit front of the brain expectations versus back of the brain planning, relapse prevention planning. So again, you know, just for today, you know, I am absolutely orienting all of my attention to not using drugs, while simultaneously making sure that if I use drugs, I've got a plan. It's this dialectical balancing of touchdown every time mentality, which apparently quarterbacks, I don't know this personally, but I have been told that quarterbacks, they really do have a touchdown every time mentality. Like, you know, we want to win now versus winning is an everything mentality. It's really how you live your life and what you learn from your life, and habit change is hard. So that's the notion of dialectical abstinence. And for those of you familiar with DBT for eating disorders, you'll see the same concepts in that approach as well. All right, so I want to keep us moving so we have plenty of time for questions and we get through the bulk of the material on time, which I think we are positioned to do. So, in DBT, in the DBT skills, there's a module called mindfulness. And in that module for mindfulness, Linehan talks about states of mind. States of mind being emotion mind, when your behavior is under the control 100% by emotion. Reasonable or rational mind, that's when your behavior is under the control of complete reason, kind of devoid of any emotion. And then wise mind, which is really kind of this integration of both. And you can think of wise mind as your greatest, deepest wisdom. Like I think, again, in 12-step programs, the notion of a higher power is like wise mind. For some people, it's internal. For other people, it's you know, it's God or it's Allah or it's, you know, it's the 12-step community, whatever it might be. But really what marks wise mind is deep wisdom. And it tends to be wisdom that's sustained over time. It doesn't just ebb and flow with mood. And the other thing is that it's not only about what's needed for me, it's also what's in the interest of the community at large. So again, there's kind of a balancing act. And this is, I think, a super important concept because so often all of us, including our clients, and certainly including our clients with borderline personality disorder, they will make decisions. They will function as if when they're in emotion mind creates factual mind. Well, it really doesn't, so you get really mad, at your boss, and, you want to quit, and so you go quit because your boss said something to you that hurt your feelings. But really, if you stand back and really get your emotions down, you down-regulate, and you have enough distance from, whatever the situation is, that you can kind of just see a little bit more at a 30,000-foot view. You have a bigger pan awareness of the situation. And then maybe you realize, actually, my boss is usually not this way, and it did hurt my feelings, but, I suspect it's possible that my boss is having a hard day. I know some things are going on at work that create all kinds of conditions. So that's more of a balanced, wise mind perspective. It has emotion. It has reason. Okay, so then moving us to this. So Linehan was interested in also, how does this apply to substance abusers? And, really what we want to help our clients achieve is getting to that point where they are in clear mind. And clear mind is where they really are. You can think of it as equivalent to wise mind. And let me actually help define it by the opposite. So clean mind is where a person is now clean, but it's a little bit like they have forgotten their history. And so it's a little bit like, they're going along, they're clean, but they've closed the door to remembering how hard life was, what their usual cues are, how vulnerable they actually are, particularly in certain contexts. So it's a little bit like they're cavalier about their recovery. And I think this is where, again, if we look analogously to 12-step, this notion that, once an addict, always an addict. Now, we wouldn't actually go quite that far, but the notion that recovery is something that you do for life, that you've got to not only watch the front door, but the back door. So we teach our clients to be on the lookout for clean mind behaviors, where they're functioning as if, it's just no longer, they're clean. What's the harm? What's the big deal? I'm just going to go to that party and not really come up with a game plan for how I'm going to get in and out without actually drinking or whatever my drug of choice is. The other one we call addict mind. And so this is where addict mind on the right-hand side is where the person is still holding on to behaviors and engaging in behaviors that are associated with their drug use. Now, that could run the whole gamut from using drugs to actually things that are more subtle, like, having, again, in the case of an alcoholic, alcohol in the household, not getting rid of my roach clip that my boyfriend gave me 20 years ago that gives me fond memories. There's a way where addict mind behaviors keep the door also open to using drugs. So what we really want to help people figure out are what are those addict mind behaviors, and actions. So we had one client, she had many drugs that she was addicted to, but one thing that left the door open for her was she had her teeth from extended use of methamphetamines were really problematic. Like, you could look at her teeth and kind of tell that she was probably a person who used meth. So she had her teeth redone, resurfaced as a way of being able to, further close the door on using drugs and having people approach her. Other examples are having money in your pocket, anticipating getting your check and not having a plan right away for getting it deposited, again, because it increases for some the probability of buying drugs. So what we're teaching is clear mind. So closing the door in addict mind behaviors, remembering your history, remembering that your brain, whether you know it or not, remembers everything that you've got associated with using drugs. And so you've got to be on the lookout. You've got to be coping ahead. You've got to be paying attention. And it's hard work. A few more points, and then we'll go to your questions. So another, as I mentioned, one of the things that we discovered early on was that our clients with substance abusers, you remember I mentioned that they were more likely to go to quick-acting drugs than people. Now, this is important because DBT, not a huge part, but an important part of DBT is phone coaching, and that's where the stage 1 client with borderline personality disorder who's suicidal or not, but whose behaviors are out of control, before they engage in a dysfunctional behavior, we want them to be using skills. We want them to be using skills anyway in hopes that they don't engage in the dysfunctional behavior. But the idea is if they've been using those skills and they still can't figure out how to get the urge to go down, and they're at high risk for engaging in that urge, we want them calling us so we can coach them. And, you know, behaviorally, you can think about that is generalization to the natural environment. We want to pull the thread through from just you know, what happens in the therapy room into the rest of their life. And this is a perfect way for that to happen, that if they really need help and support, just as if you really needed help and support, you might call a loved one or a best friend. In the absence of people who they can do that with, who can coach them on effective tools and skills to use, they can call us for that coaching. It's a very quick call. So the problem is that if they go more fast, if they go faster to quick-acting drugs, then we reduce the potency of that particular aspect of DBT. So that's why we came up with the attachment strategies. Linehan in her book talks about 2 different kinds of people with BPD, the butterflies and the attachers. Attachers are those people where, again, the problem is that they get overly attached and connected, and the problem is actually getting them unattached, getting them to, you know, terminate treatment with you ultimately without, you know, making things worse and getting, you know, making a suicide attempt. They call you too much. Those are the attachers. The butterflies are much more like our substance dependence folks, where, you know, negative arousal comes, or stress or emotion, and they go to drugs. So so they're like butterflies. The moment we actually feel like we've got them in our hands, they fly away. And in their case, they oftentimes fly to their communities of fellow drug users to use drugs. So what we needed to do is find a way in, a wedge. So strategically, DBT assumes that engaging then these butterfly clients, these reluctant clients, is actually a therapeutic task. So remember when we talked about the stages of treatment, the first stage was stage 1. Those are the most severe and extreme clients. There's no one else that, there's not another treatment that's like a base camp for these clients. We in DBT are the base camp. So, you know, it's not like I can say, well, go send them to, you know, Joe to work on their, you know, their reluctance to engage in treatment. My only alternative is, you know, to have them hit bottom. But there's no guarantee that they won't end up dead by hitting bottom, or that they're going to be any more reluctant. So we see this as an important part of our job, is to build the connection, build the attachment, so that they actually want to engage in treatment, including phone consultation, that they actually want to call us when they're in need, versus moving to short-acting drugs. So, so we did this in a number of ways. Now, if I were to ask you, what are your effective strategies for building attachment with clients, you would probably say the same things that, you know, we came up with. So some of it is going to be, you know, stylistically making sure that you're super validating. Of course, you're only validating those things that are valid, but that you are compassionate, non-judgmental, and validating, and helpful to them. Okay, but beyond that, how do you build attachment? So we did a couple of things. The first thing that we did, and you can write this down, is we met them where they were at, literally and figuratively. So what I mean by that is if they didn't show up to session, I would literally, and I couldn't get them into session, I would literally meet them where they were at. And I would do things that made therapy and me more salient, more with a positive valence, if you will. So for example, we many times did bagel therapy, lunch therapy. I can think of an occasion where I brought my client the most awesome looking, I was a graduate student at the time and I couldn't afford it myself, but I brought her a beautiful sandwich that I had gotten from the local deli, and I was, as a way of getting her to open the door and having a conversation with me. So we literally, that's what I mean, we go to where they're at. I've had other clients where I've done Green Lake walk therapy. So, you know, and we do this all the time at Portland DBT. Portland DBT sits right along the Columbia River, or the Willamette River, and there's a beautiful path that people walk and bike. If you think about how hard it is for you or your clients when they're getting off of drugs, they're already, their brains are so, you know, they're more anxious, they're more depressed, they're more kind of, you know, again, you can't see me, but jumping out of their skin. The idea of sitting in a therapy room is super, super hard. So making eye contact. So, you know, we walk with them. So we're still, you know, doing therapy, same targets, same focus, but we're walking. So there's a movement. Same thing with cars. Now, I'm not saying you should do this. Okay, if you're thinking, wait a minute, our clinic won't let us take clients on car rides. But, you know, but ours does. So that was incredibly helpful at making a connection. I had one client who had to have she had an abscess from her injection site, and she needed to go to the ED, and she didn't have easy transportation to get there. And I thought, you know, look, I'll go. I'll take her to the ED, and I'll wait. Now, the thing was, that was strategic on my part. All the way there, all the way back, while waiting in the ED, I was learning about who she was, and I was doing therapy with her. I was making a connection. So I've had other sessions, other clients where part of what made coming to therapy more bearable was either to make the session shorter, like 30 minutes. Again, thinking about that, you know, the avoidance of situations that create negative affects, so 30 minutes. More often, I've had clients where they needed longer sessions, so we had a good 20 minutes to help them go from really high-level negative emotions, you know, back down, so they were in good shape when they left. So those are some examples of how we work on making attachment with these clients so they are more willing and able to make use of the rest of treatment. And frankly, we don't lose them. So I want to make one comment about this, a few others, and then we'll go to your questions. So, you know, as I mentioned earlier, we did drug screens. I'm sure many of you already do this. I cannot begin to tell you how clinically important we have found the drug screens. Obviously, you know, it communicates and verifies the facts. But for many clients, what they have said is that it keeps them honest, knowing and accountable, knowing that others are going to have access to this information. Ideally, you get the test results right away. You're not waiting. Because you really, really want to make sure that if they have used, and that you know about it, so you can do a behavioral assessment, a behavioral chain analysis during your session with them on why they used. Now, we have occasions where, you know, our clients have said, listen, I absolutely did not use and your machine is wrong. You know, if we had more time, we would talk about how we handle that. But the point that I really want to make is this is a super important part. You know, I have consulted to clinics where they didn't have the means to do this, and I've encouraged them to work with their client to figure out, can a family member buy the drug screens? Can the family member facilitate the drug screens. So it doesn't only have to be the therapist who does this. If you only see them once a week or maybe twice a week with group, family members can be empowered to do the random drug screen the third time during the week. All right, so these are the skills which I'm not going to get into. I just do want to highlight that there were not a ton of new skills that we developed. We developed just a handful. And honestly, and all of these are described in Marsha Linehan's new skills training manual in great detail, as well as the other skills that were helpful. I want to highlight two, and then we'll move to questions. So my colleague, Julie Brown, she has something, she works with folks who have developmental disabilities. She developed this +1 rule that has been very helpful for me in my work with this population and others. So the idea is that you first rate the intensity of your emotion 0 to 5, 5 being the worst of the worst, 0, you have no emotion. You're just basically comatose. Add 1 to it. That is how many skills you have to use to get through that situation. This is important because a lot of clients will think, oh, well, I used my skills, meaning I was at a 5, but I used 1 skill. So what this would say is if you are at a 5, you actually have to work really, really hard using 6 different skills. All right, so that's the +1 rule. And then the 5-minute rule is one that I learned from my client. So she said, look, Linda, when the going gets tough, when I'm in the presence of the queue, I can only make a commitment to do 5 minutes, to just go from 5 minutes to the next 5 minutes. That's all I can do is 5 minutes. And so she would make this inner commitment to not use, but only for 5 minutes. Same concept as we talked about earlier with dialectical abstinence, where that commitment was remade every 5 minutes until she got through the high-risk situation. She had in her mind this beautiful idea that every 5-minute interval that she got through successfully was like a pearl that she was adding to a string of pearls to make a beautiful necklace. And it was that beautiful pearl necklace was strung together by moments of 5 minutes at a time. And that was kind of her own imagery skill that she used that helped her to be more motivated and inspired to use what we came up with then as the 5-minute rule. So let me pause here. Let me pass over to you, Leanne. I see that there's a lot of questions. And I will let you be the determinant of which you wish to address.
Okay, thank you very much. I appreciate that. We'll go ahead and get started. Okay, so first of all, someone noticed a reference that you used to the term prolapse. They said the term prolapse to replace relapse is interesting.
Yes. Yes.
However, prolapse often refers to more of a medical terminology.
Yes, it does.
Is there any reason for choosing that specific terminology?
Oh, I saw that question and it made me chuckle. You know, why Alan Marlatt, so it's his term, it's in relapse prevention, which is why we're using it, right? I've had a number of colleagues say, why are we using that term for exactly the same reason? And for a while, we actually changed it to something else. And, you know, ultimately, you know, it just made sense to actually use the word that is in the addictive behaviors, research literature, and relapse prevention. And really, the idea is pro as in propelling forward. So that's why, you know, you may choose to use, you would not be the only one who's chosen to use a different term.
Thank you.
Thank you.
The next question, and this one involves an acronym I'm not 100% sure about, but let me read it to you. Are there significant differences in DBT treatment needs for BPD men and women?
Not that I'm aware of.
Okay. Next question.
I mean, you are going to have differences in style, you know, and you would just treat those differences, you know, stylistically as you treat any differences in style. I mean, you know, for whatever reason, and it could have just been in our, you know, in our work, but boy, I'll tell you, our men had way more energy, and probably actually, as I think about higher rates of ADHD than our women. But that, you know, that you're going to have your own population differences, but in the research, there were no differences that I'm aware of.
Thank you. How would you incorporate DBT into a detox setting?
You know, that's a great question. I think, you know, so DBT is like, you know, it's just so vast and big. So in a detox setting, you don't, you know, you might need some core elements of DBT, like the philosophy, the principles, some of the team agreements, you know, just as a way of having a shared understanding of how you all see clients, how you see your role. You know, you're thinking about, you know, the targets and such like that. But in terms of like what the client actually would experience, I mean, you know, you have them for such a brief period of time. And I think honestly, like a lot of it is going to be helping them tolerate the incredible distress. So DBT has within it a number of skills in a module called the distress tolerance module that are specifically for, not surprisingly, tolerating distress. So there may be some very specific skills that you help them, that you teach them and you help them use while they're there with you, just again to tolerate the pain and difficulty of it. And then depending on how long you have them and how quickly they clear and their brain is on board, you know, you might teach them more skills. You might teach them, you know, to think through how to more actively close all of SLAM, you know, close SLAM all of the pathways to using drugs in their life and figuring out new pathways. You know, again, it's in 12-step programs, they call it people, places, and things. But, you know, from our perspective behaviorally, people, places, and things are all about high-risk situations where the person's brain has a classically conditioned association that is about using drugs, and probably using drugs then also through association makes me feel better, you know, and reinforcement. So I would be, you know, helping them think about the doors to close and pathways to a different life.
Thank you. The next question relates to medication-assisted treatment, MAT clients. And this question came in, Dr. Dimeff, when you made a reference to when clients were in therapy and they appeared sleepy, something like that. That's when this question came in. It says, do you handle MAT clients who appear sedated the same as any other client?
Yes.
Okay.
Yeah, we just see it as a behavioral skill. But what I would be doing with a sedated client, like actually I supervise a case now where the client is super sedated because she has medications that are probably not in her best interest to be on. So I was saying to the therapist, even though he's not the prescriber, that he really needs to be working with the client and the client with the prescriber to make sure that, you know, we can find a medication that don't result in the person being quite so sedated. So I still see that as my therapeutic task as a clinician to work with my client. And in the moment, it's still a therapeutic task to help them wake up. So, you know, having a cup of coffee, holding cold water, putting an ice pack or a frozen Dixie cup with, you know, Dixie cup with frozen water on, you know, around their face, anything that helps them, you know, kind of be a little bit more alert is what I'm looking for. Holding their body posture erect, even though it's very hard, because that will also communicate to the brain, awake.
Thank you. And the next question is, what happens with someone who has been in therapy numerous times who has learned that relapse is part of recovery?
Great question, and of course it's all going to depend. So let's just assume that the situation is that the hardest situation, which is that they've had really good therapy, including evidence-based treatment, including DBT. and then they came to me. Okay, so in that scenario, I would simply be saying to them, look, you and I both have to accept that your brain has learned that it's not real, that in fact relapse is inevitable. And what I want to say to you is that is super not helpful. That mentality is going to make it harder for us to get to the goal, and it's going to slow us down. And so what I want to say to your brain, whatever part of your brain is thinking, A, you have not had me, and B, you have got to, with a vengeance, work with me to close every single door, come hell or high water. Are you willing to do that? So I would kind of go like that. Now, if they hadn't had DBT, then I would just say you haven't had DBT. And we've got to be on the lookout for, this being your experience, because you're right that it creates conditions that this is just going to be like everything else. So I've got to speak to that firmly, clearly, and get them on board where they buy it early on, like right away.
And Dr. Dimeff, we've got something that I sent to you in your chat panel. Do you have a moment to look at what I sent to you? It was a rather long question. And do you see your chat panel?
Yes, so looking for insight on rolling year.
So just look at that a moment, and while you look at that, I'm going to go ahead and give some technical concluding remarks, and then if you think that that's something you want to address, we can loop back to it in about a minute. Is that okay?
You bet.
So for the rest of the attendees, I just want to remind you that when we do exit the presentation in just a couple of minutes, your browser will take you to an evaluation form on our website. And we ask that you complete that evaluation form so that we can then send you a certificate of attendance and report as appropriate, if you're a licensed healthcare practitioner in Florida, your hours to CE broker. And then if for whatever reason you have trouble getting to that evaluation form immediately after conclusion of the webinar, I'm also going to be sending you an email that will have another link. So you'll get a second chance to complete that evaluation today. And of course, if you attended the entire presentation, we'll send you your certificate of attendance within 5 business days. And then before we conclude, Dr. Dimeff, did you want to loop back to that query?
Yes, and first I just want to say to everyone, and Lee, and to you, and to Cynthia, thank you so much for having me. It was really an honor, and I hope this was helpful. And I just want to say, too, there's more resources available on our website, and I think that's your very last slide, I hope. Okay, so I don't think it is. So, okay, so to your question, let me take the second one. How effective and acceptable is it to implement skills units with group process but not regular individual sessions? So what this person is asking is that due to funding constraints, and they've significantly, they're only offering one element of DBT, and that's the DBT skills training. So this is a complicated issue. So here's what I want to say briefly. It is super, super important, A, that all clients understand that they are not receiving comprehensive DBT when they're only being provided with skills training. Now, for you, it's important to avoid medical malpractice in the event that anything happens. And for them, it's super important so that they understand that that they are not getting the full treatment, so that if their problems don't go away, they don't give hope on DBT. And this person is saying that she had to end because she has to go somewhere else. I'm so sorry. So I would say that. And then in terms of the research literature, what we know is that when DBT skills are provided in a comprehensive program, meaning that all the clinicians that are providing services really know and understand and do DBT from a theoretical and philosophical perspective. They know all the skills. They have consultation team, and there is a unified suicide protocol. You're probably okay. Now, we've developed a way to adapt to do this in Portland DBT. Shelley McBain in Canada at the Center for it's CAMH, Addictions and Mental Health Services. They've also done the same. That's skills training only, but it's this embedded fashion. So I think I'll leave it there, just knowing that we're going over and people are needing to get to their next appointments. Leanne, if that's okay.
Okay, wonderful. Thank you so much, Dr. Dimeff. It's been very interesting for the past 2 hours. We appreciate you joining us and sharing your expertise with the group today. And of course, I want to thank all of our attendees for participating in the webinar today. And then also finally, in conclusion, I'd like to thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's program. So to everyone, have a great rest of your day, and do please hold an equity evaluation. Thank you and goodbye.